Welcome everybody to a rewatch series, a special series of The Pitt, a show that Matt and I love. I'm Dr. Mike Todorovich, this is my co-host Dr. Matthew Barton, and this is something a little bit different to what we usually do. We started watching The Pitt, or at least I did, and I got Matt into it. I love the show, and there's so much medicine and anatomy and physiology. Anything related to the human body, we love, and we thought this is a great opportunity to do a rewatch, talk about the characters, talk about the people we love, the people we hate, but also what's happening when they talk about all the medical mumbo jumbo, sort of break it down. So we're going to do episode by episode. This is the first, season 1, episode 1.
That's all I've watched. I've only watched episode 1 where you've watched the whole series.
Yeah, I've moved forward with it. I can't help it because my wife's loving it. So I think I'm up to episode 6 of the first season. There won't be any spoilers, so we'll just go through episode by episode. In this first one, we're going to have to set the scene a little bit. So the first 10 minutes or so, we're going to introduce who the characters are, what they're doing, whether they're an intern or a resident or an attending, and what the hell any of that means.
Yeah.
So it's important for us to say that this episode, tell me if you agree, with this series, we're not doing, this is just for educational purposes only and for fun, right?
Yeah.
None of this is medical advice. We're not medical doctors. We are educators. We teach people how the body works, and that's sort of part of what we want to do. Have fun and teach.
Yeah.
Okay.
Agreed.
Good. We got the disclaimer out the road. Let's now start talking about the episode. It starts 7 a.m. The sun is rising. The morning, Pittsburgh, horizon.
Where's Pittsburgh, by the way?
Pennsylvania. I had to Google it. Sorry for the US audience. So we open on the morning, 7 a.m. And it flashes to a gentleman wearing his scrubs and a jumper. And he's got his earbuds in. And he's walking to work. And this is our main character, our protagonist. This is Dr. Michael Rabinovich, called Robbie, Dr. Robbie, affectionately.
Robbie. Yeah.
So Dr. Robbie's walking to work. He's got his earplugs in, and a song, this funky song's playing. And I wrote the song down because I Googled it. It's Robert Bradley's Blackwater Surprise playing the song Baby, very funky.
How did you find that?
I Googled it, very easy. And he's going to work, and he walks into the hospital. And as he walks into the hospital, it's interesting because the music starts to dampen, and then you start to hear
All the background noise.
which is people in the waiting room of the emergency department. So men, women, children, babies starting to cry, scream, yell. And the music, the fun, relaxed music dampens and that. So it's sort of the anxiety starts to build as he gets to work. He takes his earbuds out and he walks like down a hallway and he stops at a photo. And the photo has a picture of a man wearing, his white coat, stethoscope. And it says...
It's more an American thing than we don't really do that in Australia much, do we?
No, not really. Not at all, really. And it says, now, his name, I need to get this correct. Dr. Montgomery Adamson is what it says. And Robbie sort of stops and has a bit of a weird look. And we don't know what this means. We don't know whether it's somebody he likes or hates or is still there, has quit or
literally looks up to.
Literally looks up to on the wall, figuratively and literally. He walks past and then he gets confronted by 2 nurses. They bombard him either side and they go, I heard they're selling the hospital. And he dismisses it. He's like, he's good at dismissing.
Happens all the time.
Yeah, he's like, no, they always offer this. Don't worry about it. As he moves past them, he goes to the nurse station in the middle of the emergency department, and there is the charge nurse, Nurse Evans, right?
Yep.
And so Dana Evans is her name, and basically she goes, you okay? And he goes, yeah, why wouldn't I be? She's like, you going to be okay today? He's like, of course. And again, dismisses her. We don't know what any of this means. Mm-hmm. He then changes the subject and goes, where's Abbott? We don't know who Abbott is. Don't know if it's Abbott and Costello. Don't know who. And she goes, getting some fresh air. And then it was sort of a weird look. And then scene changes and the scene then goes off and cuts to a lady who's in a toilet, holding onto the toilet bowl, spewing her guts up into the toilet. We soon find out that this is a senior resident, Dr. Heather Collins. And that charge nurse, Nurse Evans, walks in and basically goes, pregnant, huh? I've been pregnant before. I vomit all the time. And then sort of brushes over it.
Exactly like that.
Sort of like that. She's got that tough...
With a cigar in her mouth.
Yeah, vomiting, eh? Yeah, I've done that before. And then sort of brushes over it and goes, listen, Robbie, he hasn't worked today in 4 years. It's the anniversary of Dr. Adamson's passing. And so we then can put two and two together and go, oh, okay, that guy looked up to on the wall as Dr. Adamson, he's dead. Obviously meant something to Robbie. Robbie hasn't worked in 4 years on this day, so maybe today's going to be a
Take it easy on him.
particularly rough day for him. And basically, Heather Collins is like, whatever, she doesn't really care.
I mean, she just spewed her guts up. Why
That's
would she?
true. I think she's got more important things at hand, which is the pregnancy. So
Which she did say she's not going to tell anyone or something, right? Until it's 12 weeks.
yes, yeah, that's right. So I don't think Nurse Collins has any desire to tell anybody that she's working with that she's pregnant, or maybe actively hide it potentially.
Yeah,
We'll
and
see.
It sounds like she's lost a baby before.
Oh, right. I didn't think that. You reckon that's the
Well,
case?
I think she said it this time. 12 weeks this time.
Oh, I didn't notice that. Okay, because I know she doesn't have any children, and so this is her first child, and we don't know who the father is, and so.
I got suspicions, but keep going.
Well, my wife was talking to me. She goes, "It's Robbie." And I'm like, "Oh, okay."
There were some signals midway in this episode that made me think Robbie.
Well, maybe I missed that. Anyway, we can talk about that. So she's also said Nurse Evans says to Dr. Collins, Robbie still blames himself for Dr. Adamson's death. So again, we don't know what's happening there with Adamson's death either. Then the scene cuts to Dr. Robbie on the roof of the hospital, where he meets a man who's standing over the edge of the barrier,
Looking down over the building.
yes, basically insinuating he's going to jump, right? And Robbie's like, what's going on, Abbott? And so this is Dr. Abbott. His full name is Dr. Jack Abbott. He's an attending at the hospital. Now, look, we met Heather Collins, who's a resident, and now we've met Dr. Jack Abbott, who's an attending. All these different names come up within the medical industry. So can you just...
You want to do it now, or do you want to do it when
No,
the
let's
shift
do it. Let's do it now, because we're going to come across med students, interns, residents, attendings. What are they? I don't
Okay.
understand like the hierarchy in the medical system.
So we're obviously in Australia here,
Yes.
and the wording is slightly different, but there's a lot of overlap. So we'll shortly encounter MS1 or 2 or 3 or 4.
What's MS?
MS is medical student.
Right.
And then we go to intern.
Yeah.
Now, intern is the same term that we use in Australia. So this is kind of like the first year out of medical school.
Yeah.
Sometimes called PGY1, I think, which means postgraduate year 1.
That's Australian specific.
Yeah, but they'd call it intern.
Right.
And then it would go to resident. And then resident could have a number after it. And that would indicate how many years as a resident.
Okay.
And then I believe it just goes straight into the attending, which is you kind of specialised in that area.
So Dr. Jack, so Robbie is an attending.
It's attending.
And Jack Abbott on the roof is also an attending. Yeah. So I think this episode they're the only two attendings that we come across.
Like, yeah. And so in Australia, just to contrast that, we still have medical student.
Yeah.
I'm not sure if they generally refer to MS or it's
I've
just
never heard
medical
that.
Student.
Yeah.
Then it goes intern, which is similar. Then what usually gets referred to as like a RMO, which is like a resident medical officer.
Yep.
So that's kind of like a resident. But then usually when you get on, and that I guess could sit for a period of time until you choose specialty.
Yeah.
And then when you are on a specialty program, either officially or non-officially, you become a registrar.
Right.
Which I'm not sure if America has that distinction.
Yes.
And then once you're a specialist in Australia, it could be fellow or a consultant. That would be the equivalent to an attending.
Right. It's complex.
Yeah.
It's complex. Okay, so we're going to come across med students, interns, residents, and attendings. I'll outline them where I can, where I remember, if I've written it down. Okay, so we're on the roof. Robbie's talking to Abbott. Abbott's basically is looking over the edge and is talking about so he's just finished his shift, right? So 15-hour shift, right? Robbie's just...
Night shift.
Yes. So Robbie's just started his 15-hour shift. Abbott's just finishing. And Abbott said, the last 2 hours of my shift, I was coding a guy, a veteran, who was hit by a drunk driver. Now, they just say, I was coding somebody. What do they mean by that, coding?
I think it's basically just a life-threatening arrest, which can...
Like a cardiac arrest?
Generally, it's cardiac arrest, but you can have respiratory arrest. But generally meaning you're in a life-threatening incident. If it's a cardiac arrest, it means your heart activity is ceased, or at least to the point where it's non-functional.
Yeah.
And then that would obviously result in needing to apply CPR, defibrillation, medications.
So he's doing all those things for the past 2 hours trying to save this vet. And apparently the vet passes away. Obviously, Dr. Abbott's upset about it. And Dr. Robbie basically goes, look, just come inside. I don't have to do the paperwork if you jump effectively. And he's like, oh, you're a nice guy. Good on you. Walks back in. So Abbott seems down and out. I assume he's a great person, a great doctor, but he just seems like he's taking all this time. And it's sort of, I feel like it's been eating away at him for a while now. So it's not like this is a once-off. I feel like he's very jaded by what he does. So anyway, Robbie brings him off the ledge, literally, and they hop in the elevator, go downstairs, and they effectively are doing a handover.
Yeah.
Where Abbott's like...
Talk about the night and what's... patients remain.
Yes. And so one of the patients he brings up, he says...
Kraken.
He goes, yeah, the Kraken is still boarding in BH. So I assume that the Kraken is just a nickname they've given a patient because they're crazy. And then in BH, which I assume means behavioural health. So I assume it's like the psych ward. Yeah. So we've got the Kraken in the psych ward. And he says that he's catching some Zyprexa Z's. So do you know what Zyprexa is?
Oh, it would be some kind of hypnotic or...
Olanzapine.
Okay.
Yeah. So olanzapine is a dopamine and serotonin antagonist. So effectively antipsychotic. Okay. So he's taken some Zyprexa Z's is what he says to him. And then Abbott hands Robbie a note and says, this is a note that I've written, a letter that I've written for the
vet parent, the vet family.
The family of the vet that's passed away. And so Robbie takes it, pockets it, and then they split. But just before they split, Abbott says, oh, we've also got new med students, new interns today. So a bit of foreshadowing of, okay, we're going to have a bunch of new people showing up.
Is that where I make my cameo and run at the door?
That's exactly right. So this is where Matt comes in, and a naked man just wearing socks, which unfortunately every time we go and record a podcast, I go to Matt's house and that's all he opens the door just wearing socks. Yeah, he just runs past and he just goes, no more needles, no more needles. And the nurse is like, get back here. And again, that's sort of, they just look at each other, Jack and Robbie just look at each other like, this is what we're in for. Okay, so scene cuts to pregnant Dr. Collins talking to a senior fourth-year resident, so in R4. Now, I've got 15 pages of notes here. So R4, this is Dr. Frank Langdon. Mm-hmm. So this is young bloke, black hair.
Feel like you.
He's very good looking, obviously, then. But he seems to be like Robbie's pet, do you think? Like, sort of like protege. I think he's like Robbie's protege in it. Obviously smart, switched on. A couple of things happen in the show that make you go a little bit about him. But anyway, Dr. Langdon's talking to Dr. Collins and basically going, oh, it's going to be a busy day. And Langdon's like, well, it's always a busy day. We've had busier days. It then goes to another new person who's their first day, Dr. Melissa King, who's actually my favourite character.
The girl with the glasses?
Yes. So neurodivergent. I'm assuming this is a neurodivergent character. And I don't know if she is neurodivergent herself or is playing a neurodivergent character. I think she does it spectacularly well. I know people whose behaviour is exactly like that, and she does it so perfectly. But I feel like you love the character. She cares about what she does. She's very smart. She gets very excited about things. And has difficulty sort of coming to terms with various emotions that are happening when patients die or complex things happen and so forth. And we can talk about those things when they pop up. But she's Dr. Melissa King, second-year resident. And she introduces herself to Dr. Robbie and says, I'm so excited to be here, day one. Scene cuts to a patient room, and this is where we meet another senior resident. This is Dr. Samira Mohan. And so, I don't know if you remember Dr. Mohan. You will. So she's sitting there with an elderly patient who's going, back in 1974, me and my husband went on vacation to blah, 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 and then in 76. And so they're sort of alluding to that Dr. Moen's just sitting here listening to the life story of a patient. Robbie walks up to the door. He sort of just is leaning on the doorway and he's like, got a frustrated look on his face. And he's like, Dr. Moen, we're going to do rounds. And she sort of gets startled and stands up and walks out. And he's like, look, you're not seeing enough patients per hour. When you do a patient history, it's a history.
It needs to be brief.
Yes, it's not a biography, he says. And she's like, okay. He's like, you need to sort of start pulling your weight, stop wasting. He basically says, stop wasting your time listening to patients. Mm-hmm. And so it made me sit there and go, is she doing the right, like, morally, is she doing the right thing? But is he also doing the right thing because patients need to be saved?
Context specific.
But she wants to obviously work with a patient and understand them and help them emotionally as well. So it's sort of like the physical support versus the emotional support, which is always at odds in medicine because...
Well, particularly ED.
So time poor. Yeah. So I like that they sort of brought that up. Scene cuts now to the busy waiting room of the emergency department. Now, I don't know if we said it, but this is the Pittsburgh, I think it's called the Pittsburgh Medical Trauma Center, right? So it's a hospital, but focusing on trauma, right?
Okay.
So this is the waiting room and it's crazy busy. And we meet another new character. This is Dr. Cassie McKay, probably your favorite character, redhead, right? I actually like this character as well. So she's a resident physician too. And so she's in the waiting room with all the new med students and interns. She's basically introducing them to like the process, how it all works when a patient comes in. She goes, okay, they come in, they go to registration, they register. A nurse then takes them off to triage and does some vitals. And then they come back into the waiting room. And if they're not dying, they will wait until we call them.
Yeah.
And a med student's like, how long will they wait for? And she goes, 8 hours if they're lucky, probably closer to 12. And you see like the look on their face, they sort of freak out because it's horrendous. Yeah. Now, can you tell us what, it says, they go into triage for vitals. What do they mean by vitals?
The vitals would be just certain things that are done indicating the vital signs of life of a patient. So you would take heart rate, which indicates the speed of the heart, blood pressure, which is the pressure within the blood vessels.
So where the blood's pumping to the organs properly.
That's right. Respiratory rate, which is the speed of how quick you're cycling your breaths. SATs, which is the oxygen saturation in your blood. Temperature, that's generally the vitals done. And that gives you an idea if the patient is in a serious state or if they are deteriorating, particularly if they're in the waiting room for long periods of time.
Yes, and I think they even said that they will do multiple OBS over that time for each of the patient. Yeah. And again, she goes, if they're not dying, they wait.
So I think this was alluded to a bit later, but they would come and be triaged, which kind of gets broken into needs to be seen immediately, kind of stable but serious, to non-urgent, or can wait a little bit longer. Now, what they alluded to a bit later in the show is, I think, a man with chest pain.
Oh, yeah,
So chest pain is generally considered a fairly immediate rating of triage, but what they kind of spoke about a bit later was what also happens in the waiting room is they can be seen by a lab tech, which could run an ECG or an EKG.
Yeah.
They call it an EKG in America, which is essentially the electrical activity of the heart. And so if you were to present with chest pain, the concern there would be that you're having a heart attack. Yeah. But by doing an ECG there on the spot, then they can see you're not.
Yes.
Then you go back to sit in the waiting room for maybe a few more hours.
Yes, which is exactly what's happening with a particular patient that we'll come across at some point soon. So what then happens is Dr. McKay will take the interns in to see her first patient, or at least the first patient that we see for the day with her, a patient called Sherry, and Sherry has terrible burns to her hand, and she looks pretty upset. She looks a bit disheveled, crying, upset. McKay sort of has the students outside the door to begin with. She goes, wait out there. She comes in, hey, Sherry, I'm Dr. McKay. I've got some students with me. Is it cool if they come in? She's like, yeah, no problem. So now the med students come in. What happened? She says, specifically, she goes, I burnt my hand on a sterno while I was cooking the kids' s'mores. Now, as an Australian, there's two words in this sentence that I don't know what they mean. I don't know what a sterno is, and I don't know what s'mores is.
Sternocleidomastoid.
So she was cooking s'mores on her sternocleidomastoid, the strap-like muscle across her neck. No, do you know what a sterno is?
I had to Google it.
Okay.
It's basically a camp cooking device.
Like a can of lighter fluid.
Yeah, basically it's like methanol or ethanol that you would light and then it would heat things up.
Right.
Whereas in Australia it's a bit more likely to be like butane or a camp gas. We would use a gas opposed
so what do they use? Alcohol?
That was a liquid, an alcohol liquid.
Right.
Yeah.
I've heard s'mores. I don't actually know what s'mores is.
I think it's like a biscuit with marshmallows and chocolate or something.
Yeah, I think it's that. Okay. All right. Now, she said she burnt her hand on this little can stove thing. Why would she? So it sort of makes you go, okay, why? Was she camping?
Yeah. So if you could take it on face value, you could just assume that she was camping with the kids.
Yeah.
But I think if you read the bigger picture, it may suggest that homelessness could be a possibility, or even, there's no gas or electricity in the house.
Yes.
So therefore, resorting to that.
Yes. It's interesting. Okay, so
And she was kind of adamant to get moving, like, my kids had to go to school, got to go.
Yeah, she didn't want to stay there for very long, and I feel like she didn't want to divulge huge amounts of information about herself. So anyway, Dr. McKay's like, you got anything for the pain? She says no, and the nurse is like, we'll give her Tylenol and ibuprofen and a saline wrap. And Tylenol's just Panadol, right?
Paracetamol or acetaminophen, that's the one that gives you autism.
Well,
And
according to some, not according to us or the evidence, but yeah.
And ibuprofen is anti-inflammatory.
Yeah, and then a saline wrap, so it's just a sort of a dressing to keep
That would be Advil. I wonder why they didn't refer to the brand name there.
Yeah, because they do elsewhere in the show, right? Anyway, Dr. McKay's off for rounds, and this is where we sort of bring everyone together. So Dr. Robbie, he's obviously the chief of the emergency department as the attending. He brings everyone together, everyone we've met so far, plus some other new people. So he starts the rounds by introducing now the other people we haven't met, which are going to be recurrent. So these are basically the new interns and med students. So he starts by introducing Trinity Santos. So Trinity is an intern, I think probably the only intern we actually have, at least in the first episode. Trinity is the one that seems a little bit overconfident, a bit rude. She sort of like gives everyone nicknames and they don't like it. Yeah. And when they sort of call her up on it, she's just like, oh, get over it. It's just a bit of fun. Yeah. But I don't think she means to be cruel. I think this is just her way of trying to connect with people, and people just don't like it. It grates against people. Then we meet Victoria.
But saying that, she does, from the first episode, she only does that to the junior, right?
That's true.
So it could be forming
a hierarchy. Great point. Great point. So the junior to her, at least, are these two people. So Victoria Javadi, she's MS3, so med student year 3. We find out a little bit later that there might be a bit of nepotism, possibly, with it, or they allude to that there might be some nepotism in the hospital because she seems to be related to some doctors that are already working in the hospital, and everyone's a little bit, okay, what does this mean?
And that does explain why she's defiant in some cases. Like, I worked hard for this.
Yes, and she's very adamant about that. And she's young. She's like 20 years old. And they sort of talk about, wow, you're young. Are you some sort of protege or not protege, sorry. Are you some sort of savant or whatever? Then we meet probably another one of my favourite characters, Dennis Whitaker. So he's an MS4, so fourth year medical student. This poor kid, as the episodes progress, and this isn't sort of spoiling anything. He has to change his scrubs maybe a dozen times throughout the early part of this season for various reasons, which we'll get to as we move through.
That seems more like me.
Yes, that's actually true. You are an awkward goofball. But this guy's lovable.
Yeah, he is.
So very different. So Dana, the charge nurse, she interrupts, the start of these rounds and says, guys, we've got 2 trauma patients inbound, which we'll ultimately meet as episodes progress. Dr. Robbie tells them that this is the Pitt. I think this might be the first time he refers to the Pitt. title of the show, Matt. Very good.
Location.
I assume the Pitt is sort of a play on words. It's Pittsburgh, but it's sort of the basement. It's the Pit. It's sort of
What's
the
the
slums.
what's the NFL team for the Pittsburgh?
Steelers?
Very good.
Is it?
Yeah.
Oh,
'Cause
great.
Pittsburgh was the steel capital of the world at one point.
Oh, not because they're all thieves. Gotcha. Okay, I thought they were all criminals. I was totally wrong there. And he goes, welcome to the Pit. It's a busy place, so you need to be quick, you need to be efficient, and keep your eyes on the waiting room so that nobody dies.
Yeah.
And you sit there and you go, this is stressful. And they do build the tension in the show that it's stressful. And I know emergency departments are stressful, but I feel like they really make this quite anxiety-inducing. Intentionally, obviously. And now we can actually start meeting our patients.
Yeah.
Right?
Set the scene. Very good.
So we've introduced everybody. Let's go to our first patient, Matt. Virgil Straker. They walk into his room. They say, okay, Virgil Straker has a 9mm GSW to the left shoulder. And as I was sitting there and they said GSW, I remember having this look on my face like, GSW? My wife goes, gunshot wound. I'm like, oh yeah. Bit different to Australia. We probably don't get as many gunshot wounds. I don't know if we get so many that we have an initialism for it, GSW. But anyway, gunshot wound, left shoulder. And they say a CT, so he's had a CT angiogram and it's negative. So what's a CT angiogram?
Computer
Tomography?
Yeah, so it's like an X-ray, high-resolution X-ray.
Yeah.
The angiogram is angio, blood vessel, gram imaging. Generally, they'll put in contrast into the blood
So a
vessel.
dye.
Yeah, a dye, and then you can visualize blood vessels in the body.
Yeah, so they're basically saying he's had a gunshot wound to the left shoulder. Are any of the blood vessels damaged? Because if they are, he's bleeding out.
And
right?
there is a lot in that region.
Yeah, you've got subclavian, you've got axillary, you're going to have branches of those and others. And so if he's losing blood, that's not a great thing. You need that blood to be intact in the blood vessels to deliver oxygen and nutrients. But they say it's negative. But even though they did, Dr. Robbie says repeat a crit. So when he says crit, what's he referring to?
Hematocrit, which is the percentage of red blood cells to whole blood. And approximately, you've got about 45% of cellular component of your blood is, from the whole blood.
So if I were to take a litre of your blood out, 450 mils of it is going to be red blood cells.
That's right.
And that carries all the oxygen.
Yeah, so when they do a hematocrit, they would kind of see it as that proportion.
So they're measuring it because he goes, measure the hematocrit, because if it's lower, it means he's losing blood.
Well, if you lose blood, you lose whole blood.
That's
right?
true. That's
so
true.
Technically, your
Hematocrit
hematocrit
may not
wouldn't
go down.
change in the moment.
But it could measure an anemic state in which your hematocrit is low, so your red blood cells are dropping.
Well, if you've got a bleed, a slow bleed, what's happening is your body's compensating, and you're having fluid shifts. So therefore, you're going to have fluid going into the extracellular or within the blood vessels, and that's going to start diluting it out. So even though you initially lose your whole blood, slowly over time you're going to get fluid moving around in different compartments, and that, taking in fluid, if he had intravascular fluid like a normal saline, that's then going to slowly dilute it out, and then you would get a drop in hematocrit.
Yeah.
Yeah.
Okay. So he says repeat the crit, and Dr. Langdon says crits are good. Okay, crits are good. That's good. He says, okay, then discharge with Cefton, and we'll recheck tomorrow. So that's a cephalosporin antibiotic.
Yeah.
Basically, you've got a penetrating wound. You don't want a bacterial infection. Give him
Yeah,
antibiotics.
that's right.
And then he says, you want to go home? What's his name again? Virgil. You want to go home, Virgil? He's like, hell yeah, I want to go home. And he's like, off you go. And he sends him home. Beautiful. So that's our first patient. Goes off. We see our next patient.
Good outcome.
Good outcome. Or at least it seems like a good outcome. So they actually don't meet this next patient, but they go, okay, next patient is Murphy Rodenstein, 48-year-old woman with cirrhosis and upper GI bleed. She's intubated and stable after 1 unit. So, 48-year-old woman with cirrhosis, liver damage, right? Scarring of the liver,
yeah.
right? Which you assume happens due to chronic exposure to some sort of toxin or damaging agent. Right?
Yeah.
So probably alcohol's the number one, but it can be other things,
Alcohol, viruses, fatty liver disease.
right? Yeah. And then it says upper GI bleed. So the GI is...
Gastrointestinal.
Yeah. So she's got cirrhosis and she's bleeding in her abdominal cavity. They've intubated her. Okay, so they do this a lot intubate.
Yeah, so usually what my assumption here would be cirrhosis, liver failure, the blood going to the liver is backed up, which we call portal hypertension. As a result of portal hypertension, you do get something called varices, which is like varicose veins.
Yeah,
But-
sort of like sort of the blood vessels sort of out-pocketing, creating these little weak.
Yeah, and they're fragile.
Yeah.
One particular location of that is around your esophagus. They can rupture, which then means they bleed into the stomach. You vomit it out, so you can lose rapid blood very quickly, which is life-threatening. But you also have the risk of aspiration, which means you breathe the blood back into your lungs.
Not good.
So as a result, they would intubate, which means put an artificial airway in.
Yeah. Which goes through the vocal cords
which stops the
into
risk
the
of that.
trachea.
Yeah.
Yeah, so intubation in a way is designed to stop aspiration.
That's the concern, yeah.
Right.
And so 1 unit meaning given a unit of blood because she's presumably lost quite a lot of blood.
Okay. But before they see this patient, they get interrupted by a patient in a wheelchair that's sort of sitting at the end of the hallway. This is Louis Cloverfield. And they go, Louis back. Louis got a blood alcohol mat of 0.42.
Well, they actually said 420.
Sure, but
So that's
our conversion.
So an American 420 milligrams per deciliter
Yeah.
is equivalent to 0.42%
Yes, blood alcohol.
blood alcohol.
Okay, so no alcohol in the blood, which is hopefully you and I right now.
0.00
I don't know what's in your cup right now, but this is you and I right now is 0.0, right?
Yep.
Basically.
So
What they say is that legally, at least in Australia, 0.05 is your
0.05.
legal limit to be able to operate vehicles.
or in America, 50.
Right. So is it the same legal? Maybe it's a
I
state
think
thing,
different
but-
states might have a little bit more, like maybe 80.
Right. But anything over 0.05, you do feel a change in your cognition, and alcohol is
Coordination.
affecting you
Just say
physiologically.
nervous system, yeah.
And that's 0.05.
Yeah.
So do you know how many times over Louis is to the legal limit? 8. Over 8 times.
okay.
Over 8 times.
So he's 420. I'm just
Yeah.
going to use the terms they use.
Yep.
For 300, you're at risk of coma,
Right.
and 400, you're then at a risk of respiratory depression.
Well, okay,
And
so
so
that's,
he's 420.
that's interesting because they go blood alcohol of 420 when he arrived at 11 p.m. last night. Now, remember, it's 7 a.m. That's the start of Robbie's shift. We didn't say, we probably should say it now, that each episode of The Pit is 1 hour, but it's also 1 hour real time.
Yeah.
So the first hour of the episode is 7 a.m. to 8 a.m. And then the next episode is 8 a.m. to 9 a.m. So anyway, so they said that Louis came in the night before at 11 p.m. with this blood alcohol. And Dr. Collins, so they go, okay, it's 420. And Louis smiles and goes, I've been cutting back, right? And then Dr. Collins, so pregnant Dr. Collins goes, how is he still breathing? And Dr. Robbie goes, that is a lethal dose for you and I, but happy hour for Louis. And then I think it may have been Dr. Langdon says, we sobered him up and gave him 2 rounds of lorazepam. And so when you think about, so obviously Louis is an alcoholic. He ingests huge amounts of alcohol and he's gotten used to it, right? And so when you get that alcohol tolerance and alcohol dependence, it changes your neurochemistry significantly. And to make a complex story a bit simpler, you got excitatory neurotransmitters that send signals and inhibitory neurotransmitters that dampen things down. The inhibitory ones are GABA. That's not all of them, but GABA is a prominent one, and an excitatory one is glutamate. So when you drink alcohol, it has that depressant effect, right? So it stimulates GABA and suppresses glutamate. So stimulates the inhibitory and suppresses the excitatory. But your brain doesn't like that because your brain wants to keep a happy, healthy balance. So it sort of does the opposite and goes, well, if you're amplifying GABA, I'm going to make less GABA receptors.
Yeah.
And if you're going to be suppressing glutamate, I'm going to make more glutamate receptors, right? And so for an alcoholic, if they keep drinking, in a way, it does balance itself out strangely. Yeah. But then when they withdraw from the alcohol, now they don't have the GABA activation, so the GABA drops through the floor, and now you've got glutamate with more glutamate receptors. It goes through the roof. So you've got this excitatory signal in the brain, and you can have seizures, and you can have tremors, and so forth.
And they did look at that.
Yes. So what lorazepam does is it sort of boosts the GABA network.
Or the sensitivity of it.
Yes, to sort of just stop the risk of seizures and tremors. And like you said, they said, show us your hands, Louis. And it's still shaking. And he goes, give him some more lorazepam, basically. So that's our boy, Louis. I like Louis because he was just so smiley and happy and so forth. They then move off to the next patient, bar fight. A complete avulsion of tooth 8. So tooth 8 is the front right tooth. Yeah, front right incisor, right? And a complete avulsion just means it's been knocked out, right?
At the root level.
At the root level. So complete knockout. And they go, smile for us. I don't know the patient's name. I didn't write it down. They said, smile for us. And he smiles and he's got that sort of Mad Magazine missing tooth smile.
So this would be considered a dental emergency.
Yes.
Because once the tooth is out, you've got a finite time to get it back in.
Yes.
And so ideally you'd want to get it back straight in because the root is still alive.
Yes.
And so if you're able to get it back into the socket, then the cells may be able to survive and you might be able to save the tooth.
Yeah.
But the longer, just like any body part that comes out, you've got a finite amount of time before it will start dying.
Yeah. And then but Dr. Robbie, being the smart attending that he is, he says, where's the tooth? And he goes, I don't know, Doc. And he goes, do a chest x-ray. And he says to whoever's around him, because they're doing rounds, he could have aspirated the tooth. So effectively breathed it in and not realised in the fight. And interestingly, if you look at aspirating small objects, breathing them in, you go down the trachea and then it breaks into two, into the left and right bronchi. There's one of those two bronchi where you probably more commonly are going to have things aspirated. Do you remember which one it is?
It's been a while since I've done that. I think right.
Yeah, the right main stem bronchi because it's more vertical and wider. So that tends to be where...
I remember once I was teaching anatomy with a cardiothoracic surgeon and he had a call in, I think a lady, a lady thought she had aspirated a macadamia nut.
Right. I was going to say a nut.
ED kind of said, no, I think you might have just choked on it and spat it out or something.
Right.
We'll send you home. But then she had aspirated into the top right lobe.
Bronchi. Oh, lobe.
And he had to go in, it was around Christmas, he had to go in and remove the whole apical lobe.
What?
Because it became completely infected.
Oh, wow.
So that was a macadamia nut.
So it's important to get the x-ray. Yeah. Incoming patient, Matt, 42-year-old Sam Wallace. So they wheel him in, the paramedics are wheeling him in, they all turn around and it says, okay, blunt head with agonal respirations. So what does agonal respirations mean?
Just gasping, like last...
Abnormal though, right?
Last effort respirations, which is very reflexive.
Yes.
Like really just the last ditched effort to get some kind of oxygenation in.
Yep. So blunt head trauma with those agonal respirations, collapsed on a train track, right? So this is, remember when I said Nurse Dana interrupted them in their rounds and said 2 trauma patients coming in? So this is one of them, right? They said we couldn't tube him, referring to an endotracheal tube, so intubate, right? Which basically means like, you know, they can't go through the vocal cords and into the trachea. They said they have to give him an LMA, which is a laryngeal mask airway.
Okay.
So this is still going into the oral cavity, but it sort of just sits on the vocal cords. Yeah. Now, that's sort of like the next best option for them, but you can still aspirate here, right? Yeah. Because aspiration is bringing things sort of up and down into the airway, and the airway's still available, right? So they couldn't intubate him. So apparently he knocked his head while helping a lady who fell on the tracks, which was sort of going to...
She's the next one.
Yes, and so the next little bit, they go back and forth between the two patients. So this lady coming in right behind him, she has her right lower leg, she's got a degloving injury. So what does that mean?
Exactly as it sounds.
She was wearing a glove on her foot and they took it off.
So basically the skin and subcutaneous tissue gets removed off. A bit like, you know, if you remove the chicken, they remove the skin off a chicken.
Right.
Before you prepare to cook it.
So she's had a degloving incident on her right lower leg.
Now, obviously the concern there would be loss of blood.
Yes.
that tissue would die or big infection risk.
Absolutely. They show it. Looks pretty
Gory.
horrific. Yeah, they did a good job, I think. I think it looks quite good. It looked a little bit fake from my perspective, but I think they did a pretty good job.
It looked a bit like the guy from Stranger Things.
I did. Vecna.
Yeah.
Yeah, it had that Freddy Krueger sort of look to it. They show it, then they go back to the guy that jumped on the tracks to save that lady. So the Good Samaritan is what they refer to him as. This is the guy with the blunt head trauma, right? So they go back to the Good Samaritan and they have a look and they go, the pupils are 4 millimeters and reactive. And then Dr. Robbie goes, that's good. So when they say reactive...
The light.
Okay, so they're saying that we know that our pupils, when you put light on them, they constrict to limit the light. Then when you take the light away, they dilate to try and get more light in to be able to see appropriately. This is regulated at the brainstem level, right?
It's kind of like doing a patellar reflex.
Yeah.
With your knee, boom.
Yeah.
You want to see it kick out.
Yeah.
That's just sensory in, motor out.
Yeah.
Same thing, but we're using your eye, and this is more looking at the brainstem function.
Right. So they're basically going, is this brainstem?
Yeah. Optic in, ocular motor out.
Yes.
Yeah.
So they're the nerves.
That's the nerves.
Yeah. Ocular nerve in.
Optic
Optic nerve in, sorry. Ocular motor nerve
That's right.
out, yes. But saying that that's all good, that's telling you that at least, because he's got blunt head trauma, they're saying, well, at least the brainstem, from this perspective, is spared.
That's right. It's functional.
Is functional, yeah. And they say meds...
At this point in time.
Well, yes, at this point in time. So they then say, what meds do you want? And they say ketamine and rock. Now, by rock, I assume they're not meaning crack cocaine.
No, that probably wouldn't help overly in that situation.
So rock is rocuronium, right?
Yeah, so it's like
Rock and rollium, I like to call it, but rocuronium.
So ketamine would be an induction agent and would kind of knock you out.
Sedative.
Yeah.
Yeah.
And then the rock would be, it's kind of a parasympathetic agent.
Yeah.
Works in that kind of group of pharmacological agents to work as a muscle relaxant.
Yeah, or to paralyze
Yeah.
the muscles.
Because they're going to try to intubate him.
Yes.
You want him out as well as all his muscles relaxed.
Yes.
Yeah.
So that's hence why. So that's the meds so that they can try and intubate. Remember, they said they couldn't. He's got the LMA in, the laryngeal mask. Okay, so they do that. They then say the monitor, because obviously they've got an ECG on him, they say AFib on the monitor and excessive bleeding, right? Because they look at the head wound and they go, that's more blood than I would expect from that head wound. So they see these two things, AFib, which is atrial fibrillation, right? And excessive bleeding. Now, the atrial fibrillation, that's simply meaning that when you look at the heart itself, you've got the atria, the two chambers at the top, and then the ventricles, the two chambers down the bottom. For a heart to contract efficiently and appropriately, the atria need to send an electrical signal and then contract to push the blood down. And then the ventricles need to send an electrical signal to contract to push the blood out. If you've got atrial fibrillation, it's meaning that the atria are sort of just contracting and relaxing too quickly so that they're not filling properly or pumping blood down to the ventricles properly, right? Now, this is not necessarily an overly uncommon thing to happen to people. And in this situation, it's not that they're mentioning it because it's happening as a result of the head injury.
So it's not like you fainted from it.
No, it's what I'm thinking is that they go, well, he's got the AFib and is bleeding too excessively. So the problem when people have AFib with the heart, the atrium just sort of contracting like a bag of worms, is that because the blood then doesn't move appropriately through the heart, it increases the likelihood of a clot forming, right? Because funnily enough, if the atria just sort of wiggle around and contract strangely, the blood can sort of accumulate.
Coagulate,
and coagulate and form a clot and then send that clot off to the brain or other parts of the body.
Which then could have resulted in him fainting.
Maybe, but they know he hit his head and that's why he fainted. Or passed out. So the thought is that, he had the AFib before any of this happened. And so they've given him an anticoagulant to stop the risk of clot from his AFib. And that's why he's bleeding excessively, right? That's what I thought. Is that what you think?
Oh, that's what they definitely alluded to.
So then Dr. Mohan, Dr. Mohan's the one that likes to spend excessive time with the patients.
Okay.
Right? Dr. Mohan says, well, he's probably on an anticoagulant for pre-existing AFib, So confirms that.
DOAC.
Pardon?
I think she said check DOAC or something.
Yes. So she says, check his medical records for DOAC, which is direct oral anticoagulant, right?
Which is a bit different to, like, some patients on with AF would take something like warfarin, which is kind of a vitamin K antagonist.
Okay, yes.
Whereas a DOAC is direct, and so it's kind of just targeting one particular anticoagulant enzyme.
Or clotting factor.
Clotting factor.
Yeah. Okay, so she then says, stand by with 4-factor PCC if there's a brain bleed, right? So this sort of sounds quite complex. Do you know what the 4-factor PCC is?
Well,
what
PCC,
it stands for?
prothrombin complex.
Concentration
complex. So looking at 4, you said 4.
Yeah.
4 particular factors that play a role in the clotting cascade.
Okay, so so normally we cut a blood vessel, we don't want to bleed out. It's a big deal. So we have these factors, these what called clotting factors that mostly the liver makes, right?
Yeah.
That one of them activates the next one, and there's like 13 of them, okay? And the whole point of having 13 clotting factors that all activate each other is they can amplify quickly to have a nice, big, massive clotting effect, but also can be regulated. That also allows for regulation at each step, right? Yeah. So the reason why they said 4-factor PCC, so 4-factor prothrombin complex concentration, is that there's 4 factors that are dependent on vitamin K for them to clot. Yeah. And you spoke about warfarin being potentially an anticoagulant that a patient might be on. And like I said, that sort of blocks or stops vitamin K. Yeah. So they ask Dr. Mel, right? They go...
So she's your favourite?
My favourite. With Whitaker, right? Dr. Robbie tests Dr. Mel and says, what are the 4 factors? And what does she say? Do you know what the 4 factors are?
2, 7, 9, and 10.
Yes. So factor 2, 7, 9, and 10, they're the ones that need vitamin K. So what vitamin K does, I don't know if this is becoming a little bit too complex, but what vitamin K does is it makes those factors really negative, right? And making them really negative makes calcium bind to them. And calcium acts like a tether to hold these factors at the busted blood vessel so that they can then form the clot and fix the blood vessel, right? So they go, okay, let's get this 4-factor PCC. Do you reckon that explains it well enough for people? Okay. Now they go back to the lady, because this is with the guy that saved the lady. This is the Good Samaritan. Yeah. So now they go back to the lady who fell on the tracks. Apparently the degloving is because the train ran over her foot.
Against the platform of the train. So
yes.
Friction ripped it off.
How disgusting. When they said that, I went, ugh, that's horrendous. They don't really do too much for this patient apart from stabilizer, and they say she needs a surgical intervention because she's also broken her foot.
So that's when a new character came in, like a surgical resident or something?
I don't know if she's come in yet because they basically said she needs surgery, call the surgery consult down.
Okay. Right,
so I think this new character will come in shortly. Okay. They then go back to the man, the Good Samaritan, and they try and intubate him, which they end up doing successfully. And then the surgeon has come in. Okay. And she goes, status.
She's a bit more like you, actually, this one.
Yeah. Confident, strong, assertive, very intelligent. I don't know her name. I don't think they actually introduce her formally in this episode.
If they do, it's very quickly.
Yes, because I haven't written it down because I don't know her name. So basically she goes, update me on his status. And they go, GCS 5, what's that? What's GCS?
Oh, so GCS refers to Glasgow Coma Scale. Yeah. And this is just basically a score between 3 and 15. 15 meaning what we are now.
I mean, wow, one of us. Wide awake and conscious.
That's right.
Yeah.
3 being unconscious.
Fully.
Not
responsive in any particular way.
Yeah, and they'll be testing it through verbal, motor, and in reference to pain.
Okay, so they say he's a 5, which is pretty unconscious, right? Yeah. So he's not really responding to much. They say to her, probably anticoagulated. She says, with what? And they go, we don't know, there's no medical records. She says, call for an FFP? And they say, no, we did a 4-factor PCC, right? Now, Do you know what FFP is?
No.
So that's fresh frozen plasma.
Okay.
So here, this is another thing.
Oh, so it's bringing in more clotting factors.
Yes. So, you've got various options if somebody seems to be bleeding a lot.
And she would be seeing this from a surgical point of view.
Yes.
Yeah.
So they're trying to take like a bit more of a specific focused perspective by going, we think he's on an anticoagulant for AFib.
Yeah.
And she's like, let's clot him,
I don't
throw
care.
in the plasma. So when you take blood, right, you can take a number of things. You take the whole blood. You can take the whole blood, and you can separate out the red blood cells, and you can separate out the plasma that the red blood cells.
So when I give blood, I only do plasma.
Yeah.
So it goes out, spins in a machine, and they put the red cells back in at the end of the donation.
Yeah.
So they would take 800 mils from me of plasma. In that would be the clotting factors and stuff.
Yeah, and it has pretty much all of them.
Yeah.
Right. So then you've basically got your whole collection of clotting factors there, and she's like, FFP, and they go, no, we basically did a PCC. The surgeon then goes, okay, give him mannitol to reduce brain swelling and send him for a CT. And then she walks out of the room. So mannitol, it's like a sugary...
It's hyperosmotic.
Yeah, so this is interesting, right? If you give somebody mannitol, it stays in the bloodstream, doesn't cross the blood-brain barrier, so can't get into the brain. But because it's hyperosmotic, it means it has a pulling force on water. So it pulls liquid or water towards it.
Yeah.
So as it's sort of going past the blood-brain barrier, any of the fluid stuck in that cranial vault will get sucked out to hopefully reduce the brain swelling.
Intracranial pressure.
Yeah. Can I ask you a question? So if somebody has swelling in the brain, there's something called the Monroe-Kelly hypothesis. Can you just quickly talk about what that is?
Well, your skull is like a box. It's
Speak for
a hard,
yourself.
rigid outer, not covering, but
Casing.
Casing,
Yeah.
And inside it is three main things. There's brain tissue, there's CSF, which is cerebral spinal fluid, which is the stuff that bathes your brain, and then there's your blood.
Yeah.
Now, if any one of those three things increase, because it's a finite volume, we know that there's an inverse relationship, volume to pressure. So if you put more things in the box, the pressure.
What's in the box?
Sorry, the pressure's going to go up.
Yeah.
So when it comes to head injuries, the concern is you could get fluid via like edema, or you could get bleeding. Okay, and if that starts to happen, then you get increased intracranial pressure, and then that causes a pressure on the brain, and the brain
It physically squishes
the brain isn't a tough organ in the physical sense.
No.
It's kind of got the consistencies of, what would you say?
Like oatmeal that you put in the fridge overnight.
Yeah, like butter.
Oh, butter.
Like, butter in the fridge.
Yeah, okay. Yeah, I
Yeah,
think maybe more
squishy
like
bit.
oatmeal.
Okay. In any case, it will start to get squashed.
Yes.
The skull's not going to expand.
No.
The brain will get squashed.
Yeah.
And, once the brain starts to get squashed, then we start to see changes. And that's hence why they did the pupils, because that particular nerve,
Yeah.
particularly the ocular motor, which helps move the eye, but on the outer part of the nerve is the sympathetic fibers. And if they get squashed from intracranial pressure, it stops the motor action to regulate the pupil.
That's it.
And then the pupil, they call it blowing out,
Yes.
which
Blown,
means
yeah.
blown pupil.
Yes.
And not being reactive.
Okay,
or at
perfect.
least equally. Yeah.
Next minute, a lady in a pink suit jacket walks in and asks to speak to Robbie.
A what jacket?
A pink suit. Is it a suit jacket?
I thought it was just was it pink?
It was pink.
Oh, was it?
Yeah. Believe me, when I wrote these 15 pages of notes, it took me 6 hours.
Were you like pausing?
I was Yeah. It took a long time. Look, I love the show, so I'm cool with it. So this is the chief medical officer for the hospital, for the whole hospital.
Is that what they're called?
The CMO. Yeah.
Oh, okay.
So I don't think she's a doctor. I think she's just the medical officer,
Administrator.
an administrator, right? She says, "Can I talk to you?" Her name's Gloria Underwood, and Robbie's like, "Later, Gloria," and sort of just like fobbed her off and quickly. He's like, I'm busy, Gloria. Robbie goes back to the lady that fell on the tracks. They say her nerve block is complete. So,
No. You missed a bit there.
Oh, what have I missed?
Well, you missed that surgical registrar
Yeah.
who ordered the morphine.
Yeah.
and Collins.
Dr. Collins, yep.
She said no. We need her mentally intact.
Ah,
So essentially, you don't want to put an opioid, which is morphine, on board because
Yep.
that can affect your GCS
yes.
or your mental abilities. And so they're again kind of arguing here because
From a surgical perspective,
medical.
and from a, yeah,
And she's like, I need to do an examination.
yeah.
And then she's then ordered a popliteal block.
Right.
Yeah.
So that's behind the knee.
And then she's going to go,
Gotcha. Because
So-
I haven't been able to speak to this patient yet.
Yeah, no.
Because the patient doesn't speak English
Yeah.
and they don't know what language
Yeah.
she's speaking. So they've had no way to converse with her so
Mm.
far. So they haven't been able to do any patient history or talk to her about the event or let her know what's actually happening
Yeah.
with it. So that's a good point.
So that's just lignocaine, local anaesthetic in the popliteal fossa, which is behind your knee.
yeah.
That's where the sciatic nerve branches off into the column perineal and the tibial. So you can block that. That means everything below the knees numb.
Numb. Yeah. And lignocaine's a sodium channel blocker, right?
Yeah.
So it stops the neurons from firing. If you stop the sodium, you stop the
It's
firing.
like an epidural, but at the knee.
Right, okay, so they gave her a knee and epidural. Robbie goes back. They say that nerve block's complete, and they're trying to find out, again, what language this lady speaks. And Dr. Langdon starts being a smartass to Dr. Collins. So Dr. Langdon's sort of like Robbie's protege.
And even to one of the nurses. Yeah.
Yes, he's sort of being playful, smartass, while there's a medical emergency going on. So they're sort of making it seem as though these guys are so smart, they can just muck around while people's lives are at
Which is
risk.
amazing, really.
It is.
To have that kind of ability. Like, I don't think I would be so hyper-focused on one thing. I wouldn't have that.
You can't multitask,
I
my
know.
friend. So while they're, Dr. Langdon and Collins are sort of, going at each other in a fun, playful way, a police officer walks in and goes to Robbie and basically pulls him aside and says, "We think she's been pushed on the tracks, and it's a hate crime." And so now it's a whole nother of sort of storyline is starting to get kicked off with this. So the CMO, so the Chief Medical Officer, Gloria, butts in again. "We need to talk about your numbers, Robbie," is what she says.
Yeah, so this goes off to a kind of a side conversation now.
Yeah, so they walk away and she basically says, "Look, our patient satisfaction numbers are too low." And Robbie's like, "If they're alive, they should be satisfied." And he's like, "Satisfaction?" He goes, "It's not a Taco Bell. What's going on?" And she says, "We have an 8% satisfaction rate. Do you think any of these patients are going to recommend our hospital to anybody else?" It's like, if they're sick, they'll come, So anyway, they have an argument. He says to her, "You want a better satisfaction rate? Don't make them wait for 12 hours and pay the nurses a living wage and open up some beds upstairs."
Which they referred to as boarding.
Yes. And she's like, "We can't do that. We don't have the money. We can't do any of that."
And it's a problem across the whole country.
Yes.
Yeah.
Anyway, Robbie's like, "I'm out." He walks into a room where a patient's sitting on the bed. And the patient goes, "Whatever they're giving me isn't working." Anyway, the nurse goes, "He hasn't responded to mag citrate." So this patient's sitting on a bed. He's pretty upset, right? The nurse is like, "We gave him mag citrate. Nothing's happening." So that's magnesium citrate.
So that would be an osmotic laxative.
Yeah, that's trying to... Well, we'll do it... Yes. So, yes, it is. So it's basically trying to promote him pooing. He's got constipation, right? And so it's an osmotic laxative,
That you take orally.
Yes, that's right. And she goes to Dr. Robbie, "Enema?" And he like sticks his finger up in the air. He's like, "Yep, up the bum, enema time." She's like, "We're going to give you an enema," which is going to it's going to lubricate that area. It's going to soften the stool, but also distends the bowel, which triggers it to allow peristaltic, for evacuation. We quickly leave that patient's room.
Decork it.
That's right, pop the cork. So we leave again. Robbie bumps back into Gloria. He refers to the emergency department as the Pitt. She cracks it. She goes, "Stop it. It's derogatory and incompatible with the hospital's image." And Robbie's like, "You know what's incompatible with the image? Is if I talk to the press and I tell them about our wait times. I tell them about all these people dying." She brings up dead Doc Adamson, which upsets Robbie. He's like, he actually goes,
"You went there."
He swears. And he's like, "Yeah, you went there." She doesn't seem to be very nice to Robbie.
Well, I guess she has her point of view.
Yes. And he's just like, ugh. She walks away. He's a bit upset. Scene changes to that surgeon who now is walking in from the Good Samaritan into the degloving lady's room. So changes to the surgeon, walks into the degloved lady room and says, so the Good Samaritan, he's got a small left temporal, so she's telling the rest of the staff. The Good Samaritan has a small left temporal intraparenchymal bleed. So temporal's where?
Temporal location, kind of near your ear.
Yeah.
Left side. Intra within parenchymal, the brain tissue.
Yeah, parenchymal's like the organ, the main organ.
So not the big kind of extracerebral vessels.
No.
It's more the smaller internal vessels.
Yes, within the tissue itself. So small bleed, but they basically say no epidural, no subdural, no midline shift. Yeah. So no epidural.
Or that's the extradural blood vessels. That's the big ones on the outside. So when a common example there would be you hit your head around your temple, the skull fractures, descends inwards, ruptures this blood vessel, which is around an area called the pterion, ruptures it, closes back up, and that's because it's arterial and it's outside the brain, bleeds very rapidly.
And accumulates under the skull itself.
It starts to, but it will start to push the brain from one angle, and as a result, you'll see a midline shift on an image because the brain is getting pushed on one direction, which is now suggesting the brain is moving to one side.
So when we look at the brain, it's got these three layers, right? It's got that we call mater, the mothers.
Or the meninges,
right? Or the meninges. So you got the pia, which is just the soft tissue paper that lines it. Then you got the arachnoid mater, and then you got the dura mater, which is the tough one that's sort of attached to the skull, aspects of the skull. And so they said no epidural, which means the bleed's not on top of that, so between the skull and it.
That's right.
No subdural, so it's not underneath it, closer to the brain tissue itself.
That's venous bleed. That's a slower bleed, but that can also be pretty dangerous.
And no midline shift, like you were saying. So if there was a bleed of some regard, it hasn't pressed on the brain so much that it's shifted the location of the brain, which can lead to a whole range of effects.
Hernias.
Yeah. Herniations, yeah. So herniation is when an organ goes from where it should be sitting to where it shouldn't be sitting.
And in the brain, it's going to get pushed into different locations.
Little holes in the skull that's available. Okay, Dr. Collins has a teaching moment with the med students. She says if an artery is totally transected, the smooth muscle and tunica media contracts with hemostasis. So effectively what she's saying is that when we talk about damaging a blood vessel, if you damage it completely, the blood vessel has evolved to just constrict. Yeah. So basically just all the smooth muscle that's in it just contracts to the point where it really does a good job of, at least in the short term, stopping any blood leaving. That's hemostasis.
Which is also because you're now exposing the blood to the outside of the blood vessel. The outside of the blood vessel has a lot of collagen in it.
Yep.
And that is also an activator of clot formation.
That's right. Dr. Langdon butts in and he goes, but if it's a partial cut, get your umbrella out, because you don't have that strong, this vasomotor effect with partial cuts as much as you do with the full transections.
And would that be then the external and internal? With the full cut, that's bringing in both the external and internal aspect of hemostasis, right?
Yeah.
Whereas the partial cut, it's maybe just an internal trauma, so it's not the hemostasis isn't maybe as powerful.
Yeah, you're still going to have clotting effects and so forth because you're going to have exposed collagen.
Yeah, but maybe not to the extent of the other.
And you will still have vasoconstrictive effects because as soon as you damage the blood vessel, it releases chemicals like endothelin and so forth that constrict it. They grab a culture from the, so remember this is the degloving lady, the patient that we're at. So they grab a culture from the fibula before they reduce it. So which one's the fibula? You've got two bones in your lower leg.
Lateral to the tibia, so outside.
Tibia's the shin.
The shin bone, yeah.
The fibula's on the side. Okay, so that's busted, that's broken, and they say it needs to be reduced.
I think both of them are busted.
Oh, okay. Yeah. So reduce means that it's broken and overlapped, right? So they need to, reducing it means they basically need to pull on it to put it back into alignment, right? This is that gross scene where Dr. Langdon, Dr. Collins grab the leg and pull it, right? And you got the med students standing there watching, and you hear this, and you see all this gunky stuff, and you see the leg sort of spread across. It's very good. It looks very good and gross. And Javadi, who's the MS3 medical student, she passes out. And Trinity's just sort of goes, oh, we've got a student that's passed out. Like, what a loser.
But also, it happens all the time, kind of suggestion.
Yes. Now, Javadi obviously wakes up from this passing out and leaves that room. And Dennis Whitaker sort of goes, Dr. Robbie, Javadi passed out. And Javadi sort of plays it off. He's like, no, I just...
Tripped.
Just wasn't good. And he's basically just like, go take a rest. Go sit in the tea room. And she's like, no, I don't want to sit in the tea room. Anyway, she goes off, sits in the tea room. The scene goes to Dr. McKay. So that's the redhead, right? Mm-hmm. She's the one that's sort of out around triage area, talking to a patient. And this patient is Otis. So I really like this is a good patient.
This is the start of a new one.
Yeah, yes. So talking to Otis, a new patient. Patient says, look, I was fine until about 2 weeks ago after I ran the Rochester Marathon.
But then they said...
Triathlon. I know. They screwed it up.
Yeah.
They said he was doing a marathon, then a triathlon, then they said marathon again, and then he said another triathlon.
Yeah. Unless it was an Ironman, which is a marathon in a triathlon.
Anyway. So he said, I'm tired, I've got sore muscles, I've been doing a lot of marathons, so it's not like this is the first time I've done this. I tried to run this morning and had to stop after a few minutes. I was out of breath, I was buggered, I was exhausted. So they do some lab tests.
And she looked at him a bit odd at that point when he said that.
Oh, did she?
Yeah.
Oh, I didn't notice that.
Because that is abnormal.
To run that many marathons or to feel exhausted after a few minutes?
No, to start, assuming that he's so fit.
Yes.
To then run for 2 minutes and have to stop because you're breathless.
True. I mean, if you told me that's what happened to you, I would be like, yeah, that sounds... Wow, you did a minute longer than you usually do. So they do lab tests. They do an EKG, which over here is an ECG, an electrocardiogram, electrodes on the chest, looks at the electrical activity of the heart. As they place the needle in his antecubital, so sort of the elbow area.
The popliteal equivalent.
Yes, the popliteal equivalent of the elbow, the antecubital, to take some blood to do the lab tests, he passes out. And Dr. McKay's sort of like laughing, going, I didn't think he was such a lightweight. Wake up, Otis. And they realise he's not waking up.
So then you can see that's them doing a GCS, where she's eliciting pain on
knuckles
the sternum,
on the chest, yeah.
But he's not doing anything to that. He's not waking up.
Yeah.
He's not withdrawing.
Yeah.
He's not trying to push it away. He's not responding.
He's
so that will be the
unconscious.
lowest score in that particular elicit.
Great. So she's like, oh, this is weird. And then she tests his pulse and she's like, uh-oh, no pulse. Crash cart, lay him flat. So the crash cart effectively is defib, right? So defibrillator, we'll talk about that in a sec. So they pull the crash cart out, they put the pads on his chest and the paddles on his chest. And effectively, what this machine will do is you attach these two pads to the chest and the machine itself will measure the electrical activity or lack of the heart and tell you whether it's a shockable event.
Rhythm.
So effectively, what can happen is some people can go into cardiac arrest, so the heart fails, but the arrest is because the heart hasn't just stopped.
There's not flatlining.
Electrical misfirings, right? So they put this on and it says V-Tachy, so ventricular tachycardia. Yeah. What does that mean to you if I say ventricular tachycardia?
Well, basically all you see is just the QRS waves.
Sawtooth, sort of, it's just going bzzz, up and down, up and down. So it's basically saying that there's electrical activity in the ventricles, which is good, but not the right electrical activity. It's like a bag of, it's just firing off randomly, sporadically. And so what we need is a nice single firing off, which then triggers a nice single contraction.
Or it's so significant and it's not going to allow any filling. So nothing will come out of the heart.
That's right. And so it's basically saying that multiple areas of the heart are telling it to fire off, at the same time and at slightly different times. And it's like a bag of worms. So it's not filling.
Well, not quite fibrillation, more tachy. So it's just like the ventricles are just
Oh, you're right. It's not
Yeah,
fib. It's
yeah,
tachy.
yeah.
Yes.
So it's just contracting so rapidly and so quickly.
So, okay, just tell everyone the difference between ventricular fibrillation and ventricular tachycardia.
Well, ventricular tachycardia, or V-Tach, would just be the only thing you're seeing in the trace is big, powerful ventricular contractions.
Happening too quickly.
Too quickly, and it's not allowing the atria to fill the ventricles.
Yes.
So that means you've got no functional output.
Yes.
So hence no pulse.
Yes, and the fibrillation
would be the bag of worms.
Yes, the random firings. Okay, so he's got V-Tach.
In any case, nothing's coming out of the heart.
Exactly. So the machine says it's V-Tach. That is a shockable wave. So for example, if they attach those pads and it was a flat line, there's no point shocking because he's got nothing to
Restart.
Because what the shock does, and this is sort of a misnomer that people see or that people understand, is that, or misunderstand, is that they think if there's a flat line, you shock it and it gives the heart electrical activity so it can start beating again. But in actual fact, the electrical stimulation that the defibrillator does, it's there to defibrillate or de-tachy.
Like reset.
It's resetting the electrical activity, so there's just one nice electrical signal that's being sent to reset the whole heart. So it's a shockable rhythm. So they charge the defibrillator, they shock him back into a normal sinus rhythm, meaning the ventricles are now responding to the atria as opposed to just doing it by themselves and not letting any filling and ejection to happen. We go back to the Good Samaritan, Matt. So we're going back and forth a lot here. They're stitching his head up and they're talking about how no good deed goes unpunished. So they're basically saying, look, this guy's helped somebody, saved that lady's life. She fell on the tracks. He went in, got her up, but then he tripped and fell and smacked his head. This isn't fair. Life isn't fair. And I think this is a theme that sort of recurs in this show over and over again. Dr. Mel asks, has anyone notified the family, as she's sewing him up and she looks up and everyone's gone.
Yeah, she also said, will he recover? And then the other doctor there was kind of like, he may or he may not.
Yeah, exactly. And then she's left alone. It's just like, wow, it's sort of just one patient after another and they've done what they can, so they move on. All right, they go back to Otis. So we find out his name's Otis Williams, 31-year-old V-Tach arrest, which is what we just discussed. 2 weeks after, now they say a triathlon. They then say NSR with one shock. So that means normal sinus rhythm.
Are they they're moving him into a resus bay here?
Yes.
Yeah.
So because he was sort of in triage to begin with.
He was just on a recliner chair.
Yeah, they were just taking bloods and ECG, right? But when he went into V-Tach, they're like, we need to move him into a more intensive...
So this would demonstrate the change in triaging.
Yes. From
a non-urgent now to an immediate.
Yeah, well, he just had a cardiac arrest. So
Yeah.
they're going, crap, something sinister's happening here. So they said NSR with one shock, which means he's now got a normal sinus rhythm, heart's beating properly, but only after we gave him a shock. His pulse is 98, a little high, and his blood pressure is 110/60, which isn't too horrendous. Robbie's like, okay, everyone, what's the differential? So what does that mean? If a doctor says, what's the differential?
Well, what are the possible causes, possible hypotheses of why a person like this is experiencing this particular condition?
Yeah. And Dr. Collins...
Yeah, I couldn't write all these down quick enough.
Okay, so Dr. Collins goes, drug overdose, electrolyte imbalance, long QT, Brugada syndrome, WPW, right? So I just want to very quickly go through that. So he's had a cardiac event, was V-Tach, and they had to shock him. So she's thinking, what things can do that to your heart? She says drug overdose. So yeah, you can have a bunch of drugs that can affect the electrical activity of your heart, a multitude of drugs. Electrolytes, well, the heart's electrical activity is dependent on the charged atoms and elements in our bloodstream. So sodium, calcium, magnesium, potassium, right? She says long QT. So when you look at when you have an ECG done and you look at the trace, you've got different waves. You've got the P wave, which represents the electrical activity of the atria at the top. You got the QRS complex, which represents the electrical activity of all the ventricles. And then
Depolarizing.
Which means nothing to our audience, but yes. And then you've got the T wave, which is the electrical resetting of the ventricles. So they said that she goes, maybe long QT. So she's saying that the electrical event from the ventricles having its electrical activity all the way to it resetting is too long.
Yeah.
And so that's important because if that's delayed, you delay the resetting of the heart. You can get something called torsades du pont, which is basically it then fires off again too early. So if you don't reset it fast enough, it refires and then refires and refires. And you can get ventricular tachycardia from a long QT. Does that make sense? Because you need to reset it so that it's got enough time. It's sort of like the refractory period. It didn't set in fast enough, right? The refractory period means it stops it from refiring again. Brugada syndrome, which is just like a sodium channel disorder.
Okay.
So the sodium's not going in and out of the muscle properly, so it's not firing off properly. And then WPW is Wolff-Parkinson's White syndrome. Yeah. So this is an added electrical pathway from the atria to the ventricles. And so this added electrical
pathway circuit.
Yeah, bypasses the AV node. So the node that tells the ventricles to contract or beat, it bypasses it. And so Wolff-Parkinson's White syndrome can trigger V-Tachy. Right. So these are these differentials that she's throwing out. Otis briefly wakes up and then goes back into V-Tachy. And they're like, uh-oh. And they shock him again back into a sinus or normal rhythm. Dr. Collins is at the computer and she goes, okay, I'm ordering O2, so oxygen, CBC, CMP, troponin and D-dimer. So CBC, do you know what that is?
Complete blood count.
Okay, so that's what's happening in the blood.
We call it full blood count here.
Yep, FBC. A CMP.
Creatinine metabolic.
Yes, comprehensive metabolic panel. So it's looking at
like electrolytes and all that.
Yeah, all the things that the cells are turning over metabolically. Troponin.
So that's a protein that can sometimes be released when there's death of tissue.
Particularly myocardial, so heart muscle tissue. So if that goes up, you think, oh, the heart's dying in some regard. And then D-dimer.
D-dimer is clotting.
Yeah, so it's a product of clotting, which shows there might be a clot that's causing all this. So she orders all those things. She asks Robbie, hey, whoa, what are you doing? And he's sort of filling a syringe up.
Because he's doing something in the background.
He is. He's filling a syringe up. And he goes, I'm giving him 1 gram of calcium gluconate through an IV push. And she's like, we don't have the labs back. What are you doing? So effectively, he's like, I know what's going on. I've got the experience. I'm confident. I'm going to give him this calcium gluconate. Now, do you know what calcium gluconate does in this instance? What he's thinking is going on?
Well,
okay, I can tell you what he says, right? Okay. He says, look at the monitor. We've got a widened QRS and PT waves. It's hyperkalemia. Yeah. So tell us what you think. Tell us what you think.
So widened QRS, meaning the ventricle wave is being lengthened in its duration. And what was the other wave?
PT waves.
PT wave is peaked.
Yeah.
And he's suggesting, well, I can just go off the monitor to then diagnose potassium being out of range. I don't need to wait for the blood test.
Yes.
And so he's already working one step forward and going, now I need to somehow counter this high potassium and its effect on the heart.
Yeah, I reckon his thought process would be, okay, I know that you can have widened QRS and peaked, T waves, for example, and that's a sign of hyperkalemia. So he knows that. And then he goes, this guy's also been doing triathlons. He's probably damaged his muscle cells, and inside all the cells, they're packets of potassium. So if they're damaged and busted, you're now spilling potassium out into your extracellular fluid.
Yeah.
So your extracellular potassium is going to go up.
However, it was 2 weeks since the marathon.
True.
And so he's probably also thinking he's had all this muscle damage and that's spilled out the proteins, which has now clogged up the kidney.
Right.
And the kidney's now not doing what it's supposed to do. One being regulate potassium.
So doing that, damaging the muscle cells, spilling out the proteins such as myoglobin, which is sort of like the hemoglobin of muscle, that's too big for the kidneys to filter, and it blocks it up, like you said, and the kidneys can get knocked on the head.
Yeah.
And like you said,
considered a acute kidney injury.
so I think there would be a combination in some regard of the potassium accumulating. I'm just guessing here. The potassium accumulating from the damaged cells, but also the potassium not getting filtered properly from the kidneys and also accumulating. Regardless, if the potassium accumulates, think about it like this. And this is a little bit complex to explain, but I think it's important. In order for a heart muscle to fire off and send a signal for it to contract, there needs to be a charge difference from inside the heart muscle cell to outside. Now, usually you've got all this potassium inside and not much outside. And what you end up having is a charge difference from inside to outside. Now, the inside of the heart muscle, when it becomes more positive, so if you throw in positive sodium or positive calcium, it makes the inside of the heart muscle positive, and that tells it to contract, right? The thing is, though, if you've got all this positive potassium outside of the cell, the potassium that's inside doesn't want to leak out, which it normally does. And that's very important. Potassium leaking out of a muscle cell is what makes the inside negative to reset it so it doesn't contract. But if you've got all this potassium outside, the potassium inside doesn't want to go. Yeah. So it stays inside and becomes really positive. And if it becomes real positive, it fires off when it shouldn't. And that's
or it brings the resting potential much closer to threshold.
So it's easier to fire off. Exactly. And so that's an important point, right? So he goes, I'm going to give calcium gluconate. So do you know what that's doing?
Well, I think it's not doing anything to lower the potassium in the blood.
No.
But it is kind of protecting the heart from the potassium issue. So it's kind of bringing the threshold up to make it harder to stimulate.
Yes.
So it's not fixing the potassium, it's just bringing the threshold to depolarize a bit higher.
Yes, exactly right.
So this would be only a short-term fix.
Yes, that's right. It doesn't fix anything. It just stops the excessive firing off of those cells, because now because if it's super positive inside compared to outside, if you then bathe the cells in calcium, the charge difference is mitigated, because now the inside, it might still be positive, but it's about how positive it is inside compared to the outside. So if the outside's now very positive due to the calcium, it's less likely to fire off, right? Yeah. But you still got to fix the potassium.
Yeah.
So anyway.
So he pushes it in, and we see... No, actually, I think that it ends scene there.
Okay, but she says, because he goes, it's hyperkalemia. She says, okay, I don't get it, what's going on? And Robbie goes, intense exercise causes muscle breakdown. He's got rhabdomyolysis. So rhabdomyolysis is effectively when muscles break down, they release their myoglobin, and that blocks the kidneys up and damages it. He says it's knocked out the kidneys and now is not clearing potassium. Yeah. So the potassium is accumulating, like you said. Robbie goes, I bet his potassium levels are over 7.5.
Oh, I didn't hear that.
Yeah, I assume he means millimoles per litre. Yeah. I don't know why he chose 7.5, because like the normal value of potassium's 3.5 to 4.
Maybe there's threshold.
3.5 to 5, sorry.
Maybe there's kind of threshold boundaries that
for cardiac.
Once it gets above a certain number, then cardiac comes into play.
Yeah. So he goes, I bet you it's above 7.5, which is well above the normal happy, healthy range for potassium. Dr. Collins goes, if you're wrong, you'll kill him. And he goes, well, it's my ass, and injects the calcium gluconate. Scene goes to back to the degloving patient. Surgeon says, not my patient anymore, send off to ortho. So that's that sort of rude surgeon. She just like takes the gloves off, throws it and legs it. They still don't know what language this patient's speaking or how to communicate with her. The intern Trinity and the med student Whitaker are talking about fainting Javadi, and sort of like Trinity's at least teasing her while Whitaker's sort of sticking up for her. Whitaker talks about how little money he has and how long it's going to take to pay off his student loans for his medical bills. Right. I searched what the average cost of a medical program in the US is. Want to guess in US dollars?
$500,000.
Close. Between 200,000 to 400,000 US dollars, which is about $500,000 Australian dollars. Yeah. That's the average medical program. So yes, it's going to take him a while to pay off his debt.
But mind you, I could be wrong here, so American listeners correct me if I'm wrong, but I don't think in America you can get straight into medicine from school. So you usually have to do a pre-med degree.
You've got to pay for that too.
So then once you add those together, you may be looking at $500,000.
Oh boy, okay, makes sense. Trinity jokes and says she could get him $30,000 for his kidney if he wants to sell it. And he sort of doesn't know if she's joking or not.
Yeah.
She says a lot of things. Deadpan.
Yeah.
They go back to the marathon runner, Otis. QRS has narrowed. That's good. So it's gone back to being a more normal QRS, right? So it's reflecting that his ventricles are firing off a bit better. His potassium is 7.7. Dr. Robbie was right. It's above 7.5. His creatinine is 5.6. Now, usually your creatinine should be 0.3 to 1.3 milligrams per deciliter. Now,
what do they say was?
They said his creatinine is 5.6.
Okay.
Now, okay, so this is interesting because
in Australia would be different. That's again milligrams deciliter.
Yes, milligrams per deciliter.
But Australia, it's millimoles per litre.
Yes, we often use millimoles per litre. But okay, so interestingly though, they say creatinine, but they don't say EGFR, which is, so the EGFR is the glomerular filtration rate, how good the kidneys are filtering, functioning, right? And creatinine is a byproduct of muscle activity. And we know we sort of produce it at a regular-ish rate, but more importantly, it gets filtered at a regular rate. So when you look at creatinine, it gives you a good indication of how well your kidneys are functioning. But you also need to look at the EGFR to see how well your kidneys are actually functioning. And you need to really look at both together often. So my thought would be that because he's got high creatinine, are they saying in this episode that that's an indication that his kidneys aren't working?
That's my thoughts.
But he's got rhabdomyolysis. So he's going to have busted up muscles. Creatinine's going to be artificially high anyway, wouldn't it?
Potentially.
Right? So that my thought was like, oh, that's interesting. I get why they said it because it's telling you the kidneys aren't happy and healthy. But also, maybe it's just high because you've got muscle damage.
Do you get, or was that creatine that you would see?
You'd see both.
Creatine kinase and then creatinine.
Yeah.
Yeah.
This is what I assume.
But maybe the creatinines are more metabolism opposed to inner products of the muscle.
We're not clinicians. Yeah. We don't know this, so we're just working off the physiology, the anatomy and physiology. Okay. There's a little smile on Dr. Robbie's face when he hears what the potassium value is, because he was right. Dr. Collins looks actually quite pissed off. She's not like, oh, good on you, Robbie. She's like, I hate him. Because
of that reason?
I don't know. This then brings the question mark, what's their relationship, right? Because she's like, she's annoyed with him. Like she's actually pissed off with him. Dr. Collins ignores it, orders insulin and glucose. Robbie asks McKay, so Dr. McKay, why? Why are we doing insulin and glucose? And she rapidly responds, she goes, it will shift the potassium intracellularly. So do you know...
So which doctor was this again?
McKay, so the redhead, the one that's been in triage.
Yeah, she's there. Okay.
And then came back in.
Insulin, I think when it binds particularly to muscles, it increases the amount of sodium potassium pumps up to the membrane. So therefore, better regulating, bringing the more potassium back into the cell. Yeah,
so every cell in our body has this pump that throws sodium out and potassium in. And insulin stimulates these pumps. So it brings potassium in. And the problem is there's too much potassium outside.
Yeah.
And so interestingly, potassium's a weird one because we can't, by measuring potassium in our blood, it doesn't give us an accurate reading as to how much potassium's in the body because most of it hides in the cells.
It's in the cell,
right?
Yeah.
So they often, I assume in this instance, they're thinking, well, it's not necessarily we need to get the potassium out of the body, it's we need to put it back into the cells.
Yeah.
So the insulin will do that. But then Dr. Robbie said, but even though we're doing this, he still needs hemodialysis. So they still need to put throw his blood through a dialysis machine. To filter it out. Dr. Collins still seems pissed with Robbie. He pulls her aside and goes, are you okay? And she goes, are you okay? Tension. Don't know what's going on. She says, it's not always about you, Robbie.
That's my first indication of something more.
Right. So my thought then is she upset because of what's happening with herself, or is she upset with him and how he affects her?
Yeah, there's something more in the relationship. That's how I read it.
Dr. McKay explains basically everything we just said about Otis to Otis. So she's explaining all those mechanisms, all the things.
And do you think she did a good job?
I think she did a great job.
Yeah.
He talks about why his chest hurts, why is my chest hurting, and sort of goes, well, you've been shocked, and then goes through the potassium and the muscle breakdown and how the kidneys have been knocked on its head. It's a really good, the show's a really good, this is why we're doing this, like teaching lesson or multiple teaching lessons. Dr. Robbie is chatting with the charge nurse at the station, Nurse Evans, who mentions it's soon time for the arrival of the living dead.
Yeah.
What are they referring to?
Patients from nursing homes.
Yeah. So because it's like...
This was a interesting side theme.
Yeah. Well, because it's like between 7 and 8 a.m. now, right, in the show. And so what they're saying is that in these nursing homes, as the nursing patients wake up, the nurses at the nursing home will go through and do patient checks and find that a number of them haven't woken up.
Or they're seriously ill.
Correct. So they bring them into the ED. So with that, we have an 89-year-old woman who's unconscious. She enters with an automatic CPR machine attached to her chest called a Lucas chest compression machine.
I couldn't find if that's an acronym.
Neither could I.
Yeah, but I did find that it's
But it was
like
all capitalized, so I assumed it was.
Like a piston with a suction cap on it.
Yeah, it was just pumping her chest. Her hands were sort of strapped to it, and then it was sort of pumping her chest, trying to keep the blood flow going through that heart.
So allowing the paramedics to do other things at the same time, because otherwise it would essentially it would free up a paramedic to do other things. Otherwise, it's just a person doing that.
You'd be exhausted. Yeah. When they transferred this 89-year-old from the gurney across to the bed, they trap Whitaker's finger and they sort of bust his nail, and he has a little hematoma under his fingernail. They're waiting for the assisted living place, so the aged care facility, to send over the patient's directive, which is effectively their personal wishes as to whether they want to be resuscitated or not if this type of medical emergency occurs. But they don't know, right?
And they ordered, a shock and some drugs, I think.
Yes. Yeah. So they do all these things. They don't know what to do. They keep doing it because they haven't been given a directive otherwise. But then Nurse Evans runs in and goes, stop. She has a DNR, which is...
Do not resuscitate.
So they go, oh, what a waste of time and money. And they take the machine off her. They turn everything off and they go to leave.
I like this scene.
Well, it hasn't happened yet because we now see another patient come in, right? So another patient from the aged care is wheeled in, Joseph Spencer. We actually see more of him next episode, so you haven't seen any more of this. So Joseph Spencer, 79, has a fever and cough and mild Alzheimer's. His heart rate's 130, his blood pressure's 90/60, and they've given him 500 cc's of saline, which is half a litre of saline, and his temp is about 39 degrees, so like a mild fever. The paramedics say that he has a POLST, P-O-L-S-T, which is a physician's order for life-saving treatment, which basically says the physician says, these are the drugs and things that you can and can't do for this patient. They find out he's a right middle lobe infiltrate. What's that mean?
Well, on the right side, the lobe location and infiltrate meaning there's likely to be an infection.
Yep. And calls for a code sepsis.
Okay.
What are we referring to here?
Sepsis just meaning now affecting more systemically.
Yeah, that's right. So it's gone through the bloodstream. The orders are blood cultures. So this is interesting. I wanted to bring this up. The orders are for blood cultures. So what's the infection?
Yeah.
And lactic acid. Now,
I know.
this is my gripe. So they order lactic acid. What they're actually measuring is lactate. And lactate is a measure of whether somebody's in anaerobic respiration.
Yeah, which is hypoxia, probably.
Yes. Are the tissues getting enough oxygen, right? Is effectively what they're measuring.
Which could be a combination of his pneumonia or the sepsis. Or
okay,
both.
But what is leading to the low oxygen perfusion or low perfusion to the tissues? What could be?
Well, if it's a pneumonia or the lungs filled up with inflammation and it's not being oxygenated.
Yeah, so not enough oxygen from the lungs to the blood.
Or if it's sepsis, the way that the dynamics of the blood vessels and the way it's perfusing the body is being hampered. Yeah, so,
and the metabolic demand can go up. Okay, so they order lactic or lactic acid, but specifically they're measuring lactate. We go back to the elderly patient who's just passed away, the one that was on the Lucas CPR machine. As everyone's about to leave, Dr. Robbie says, no, we need to talk about respect. There's a ritual that we undertake to respect the patient when the patient passes away.
Well, even before that, the senior resident,
Dr. Langdon.
he said kind of dismissively about what are they doing at these facilities, you know? And I like Dr. Robbie here said, you've essentially got one RN to 60 patients.
Yeah.
And they're doing their best. Don't blame them. Again, it's a system issue.
Yes.
And so I like that because we have something similar in Australia where we kind of demean the aged care medicine. Like it's just this thing that happens on the side.
Yeah.
We won't put resources into it. We won't put the best, nurses and doctors in there. It's just kind of this space we don't want to think about.
Yeah. Yeah.
Yeah. And so I like that because he defended that.
Yes.
And even I think the nurse was here as well, and she said, well, they probably called 911 so they could continue caring other patients.
Exactly right.
So that was nice, I thought.
I like that too. Then Robbie's like, don't leave. We're doing this thing of respect, to respect their humanity and remember them as a person, which is a moment of silence. And the camera sort of pans through the room. Most people are respecting the moment of silence, except Dr. Langdon, right? That resident. He's sort of like very ADHD, sort of like tapping away and sort of moving his head around like, hurry up, I need to see
Which is interesting. Is it demonstrating that aspect of him or him not caring?
I don't think it's him not caring. I think it's he sees that there's more important things to do, that a patient isn't... I don't think in his eyes at the moment the patient is necessarily a person but someone to treat, right? Which is showing sort of the distinction between the humanity and the medicine.
Yes, totally.
But also, Dennis Whitaker, the med student, his phone goes off. I don't know what the ringtone was. I was trying to figure out. But it goes off and Dr. Rob is like, maybe put it on silent while you're at work.
But everyone's smirking.
Everyone's smirking. Goes back to med student, 20-year-old Javadi, so Victoria Javadi. She apologises to Dr. Robbie for passing out. Robbie sends her to triage, says, look, we need you to work with Dr. McKay at triage. And she's like...
Bit annoyed.
Yeah, she's like, you don't need to do this to me. I busted my ass, you know. She's not happy. She goes, I don't want special treatment. He's like, good, I'm not giving it to you. As they're talking, a surgeon from upstairs arrives downstairs. And Robbie's sort of like, we called for a consult ages ago. You're a bit late. And she's like, I'm here to see my daughter. And he's like, oh, is your daughter a patient? She goes, no, that's my daughter right there. And Robbie's sort of just like, what the hell's going on? Javadi's embarrassed.
Yeah.
And anyway, she's sitting there having a conversation with her mum. And Trinity, that intern, walks past and calls her Crash. She goes, oh, we're about to do, I don't know what it is, something in patient room.
I think the dialysis.
Yeah, patient room 12, Crash. And the mum said, she called you Crash? And she's like, no, she called me Crush because I'm crushing it. And the mum didn't believe it. She's like, I gotta go. So Javadi quickly walks away.
And that's an interesting dynamic as well.
Yeah, because the mum wasn't being rude.
No, but
terrible.
it's interesting because my wife's Indian background.
Yeah.
And it's interesting the dynamics with parents, particularly with the academic sides of things.
Right.
So there's a bit of that in there, I feel.
Yes.
You know, like proving yourself. Yeah.
Maybe you're right. Yeah. Javadi quickly walks away from her mum and walks away so quickly she doesn't pay attention to what room she's walking into, and she pulls a curtain aside and there's that constipated guy. He's obviously been given the enema because he's squatting over the top of a bedpan, and
He's squatted on the bed.
He's on the bed, on a bedpan, and there's poo everywhere. and he's not happy. Yeah. He's like, when do you get out of here? I'm pooing in a bedpan. Robbie goes back to the nurse's station and asks about the dead veteran that Dr. Abbott was dealing with. He asked about the dead vet. He asked about the triathlon patient, whether they've identified the language of the degloving patient. So it shows you that Robbie's mind's in 12 different places at once, right? In one of those conversations he has, we find out that basically Robbie doesn't have a lot of friends. So Dr. Langdon's there as well, and Dr. Langdon's like, I'm your friend. He's like, not really, you're a colleague. Like the way you speak to me. They talk about, whether Dr. Langdon should get a dog, and Robbie's like, it is man's best friend. He's like, then why don't you have one? He's like, I don't have a best friend, right? So he's sort of saying I'm a loner, right? I'm a tough loner. Dr. Mel comes up, asks for Dr. Langdon's help to deal with this lethargic 4-year-old.
That's right.
Right? She goes, look, we've done every test. It seems fine. He just won't wake up, basically. The kid is called Tyler, right? Won't wake up when they go in and visit him. The parents say that, he's usually got heaps of energy. And when it's bedtime, he just passes out. And Dr. Mel takes it literally. And she's like, he passes out? And she goes, no, like he's tired and passes out. I like that scene because it's just sort of like she's so
literal
on the ball and literal that she's like, he passes out. Scene goes to Trinity, and she is, what's she doing? She's relieving the blood pressure under the nail of Whitaker. And he's like, you going to give me some anesthetic? And she's like, you'll be fine. I'll stop before I hit the nail bed. And she does it really nice. She calls him Huckleberry, right? And he's like, why are you doing this? I don't like that nickname. It's horrendous. Why do you call me Huckleberry? She's like, where are you from? He's like, Omaha, Nebraska. And she's like, there you are, Huckleberry. No one knows where you're from. We go back to the degloving patient with Dr. Collins. And we find out Dr. Collins gets her phone with a map on it and says, I'm from here. Where are you from? And she points to Nepal. She's Nepalese. So they find out where she's from so they can get a language translator coming in. Javadi and McKay. So Javadi's gone to triage where McKay is. So bringing patients in from the waiting room, sort of figuring out whether they're dying or not. And they're chatting about Javadi's mum and dad. So both Javadi's mum and dad work at the hospital. So the mum's a surgeon, the dad's an endocrinologist. But
again, she's trying to be defiant here and prove herself that she worked hard to get to this point.
Yeah, because McKay goes, can I ask you a question? And she goes, I've busted my ass to get here. And she's like, I'm 20 and I deserve to be here. She's like, yeah, I know. I just want to know what's your relationship with the surgeon from upstairs. She goes, it's my mum. And she's like, oh, cool. Now, I don't know if they're doing that because they're like, that surgeon has a reputation of, I don't know, being a hard ass or being great or what. Mm-hmm. But it's sort of like, instead of just going, oh, okay, which I would think would be the reaction. It's like, oh. And I don't know if what's going through their head is, oh, nepotism. She got you in here and that's why you're here.
Well, I think that's what she's trying to prove.
That is not that.
Not that.
Yeah.
But I do wonder now there's an awkwardness that they've got to be careful with this medical student because the mum's upstairs.
I think you're right. And the dad's an endocrinologist. So he's somewhere in the building too. So they both go into the waiting room. They call the next patient, but they get stopped by this big bloke who you alluded to earlier, Doug Driscoll. He wants to know when he's going to be seen. He goes, I've been waiting here 2 hours.
Chest pains.
Chest pains. Woke me up in the middle of the night. And Javadi corrects him, goes, chest pain. He goes, what? She goes, it's chest pain, not chest pains. He's like, well, I had more than one, so it's pains. What are you, an idiot? Who is this? And McKay goes, it's a medical student. He goes, get her away from me. It basically tells Javadi to shut up. They go, look, we're going to see you at some point soon. You've had your ECG, like you said, and it was fine. So
and you're waiting for blood test and a chest x-ray.
Exactly. So we'll come get you soon. But as they go to get the actual patient, they get distracted again by a lady in line that's vomiting. She appears to be there with her son. She's holding a bowl. She looks horrendous. She's vomiting into that bowl. Okay, we go back to Otis, the marathon / triathlon runner. His BP is crashing. Otis, BP, crashing 70 over 50.
Oh, this is the nurses running to the main station.
So his blood pressure is 70 over 50. We haven't really broken that down. So what's the number over the other number?
Usually 120 over 80 if you want to be.
So 120 is how strong the ventricles are contracting.
Yeah.
And the other one's how...
the relaxation of the blood vessels.
Yeah, how the reflexive recoil, right, of the blood vessels are. So 70 over 50 is very low.
Yeah.
So
particularly for him.
And that's probably low enough that it's going to limit perfusion, so how much oxygen can be delivered to tissue. So that's not good. So they need to remedy that. And he's not on dialysis yet. So they sort of go, he's waiting for dialysis and it's crashing. So his collapse, Dr. Collins does an ultrasound on the spot and goes, he's got a collapse right atrium and right ventricle. Robbie goes, it's a tamponade from uremic perfusion. So just explain, can you fill the gap between the right and left ventricles collapsing and it being a tamponade from uremic perfusion? How do you
All right.
bridge that
So we know.
gap?
So we know he's in an acute kidney failure.
Yep, kidneys aren't working.
Kidney's not working. It's already been demonstrated through the creatine and the potassium.
Creatinine.
Yeah, creatinine. Sorry, but we know that kidneys need to filter other things. Now, when we refer to uremia, that is anything with nitrogen bases associated with it.
So things that the
Nitrogenous.
kidneys should be filtering are
Which
accumulating
will
in
be
the blood.
including urea as well. That's building up. So that's going to be building up in the blood. Now, that in itself would be irritating to tissue. Now, with your heart, the heart being mostly a muscle pump, it's wrapped up in a pericardial sac, which is basically a collagen bag that separates it from...
Which is your nickname.
which separates it from the lungs on each side.
Yes.
And that bag allows it to contract inside it without friction.
Because there's fluid that's produced.
A little
in that
bit of
bag.
fluid. It's just kind of like a little bit of
lubricant.
Layered fluid. Not much fluid, just enough to lubricate it.
Okay, so what's happening now?
And so
you're
the uremia-
accumulating these products in the blood.
It irritates the sac,
Yeah.
and the sac becomes inflamed. Any type of inflammation results in edema, which is just fluid production.
So the sac's producing too much fluid
Yeah. And then
due to the irritation.
that will then start to accumulate within that space, the pericardial space or pericardial sac space.
So if the heart's in a sac and can move around freely when
Yeah.
it beats, because it has to move when it beats, but if that sac fills with the fluid, the heart just, when it beats, it can't move. That's the tamponade.
It starts to press on it, just like we spoke about with the skull and the bleed in the brain.
Similar to.
So it starts to accumulate, which means, again, the heart is fairly soft, the pericardial sac is rigid, so it's not going to expand. The heart will start to compress, and that's the tamponade, meaning compression.
Yes.
And that means what it's suggesting is the fluid is starting to accumulate on the right side, pressing down on the atria and the right ventricle, which is the fill-in portion of the heart.
Yes.
Hence why he's got a low blood pressure.
Yes. Now, they say he needs a pericardiocentesis, which effectively, pericardio is just the pericardium, the sac around the heart. Centesis is referring to putting a big needle in and sucking that fluid out that's sitting in that sac. So they insert a needle to suck that fluid out. It's a big needle. You look at it and it's quite frightening. Luckily, Otis is unconscious at this time.
Because it has to go through, it has to go under the xiphoid of the sternum, kind of through the diaphragm, but carefully not to go into the pleural areas, because that's going to cause a lung collapse, and kind of come in to a point where you can just get the tip of the needle into the sac and not hit the ventricle.
Yes, and so Dr. Collins, who's got the needle, is like, I can't do this blind, And Dr. Robb's like, it's all good, I'll ultrasound at the same time. And he says, look for the big white, bright light point. He actually calls it a hyperechoic tip, which is just mean a super big bright light you'll see on the echo, right, the ultrasound, and that's the needle. And then she can look at it and follow it, and he's like, don't puncture the heart. And it's high tension. Anyway, they take about 3 mils out, which is what, 3 cc's, which is cubic centimeters. Yeah. Pull that out, and then they've relieved the pressure. The heart can contract properly, the blood pressure goes back to normal. Brilliant.
The Americans are really all over with their units, aren't they?
They are. They got
consistent.
milligrams per deciliter and cc's, and then they got millimoles per liter. Anyway, they go back to the room where they've just brought the mother in who was vomiting, and they've given her Zofran, which is Ondansetron. Thank you.
So was that serotonin?
Serotonin blocker. So my understanding is it does 2 main things. You've got a vomit center at the base of your brain, right, where the blood-brain barrier is breached, and whatever's in your blood can trigger the brain if it thinks it shouldn't be in the blood. If you give serotonin blocker, serotonin seems to be the main neurotransmitter that triggers that. So if you block serotonin, you block the vomiting center in some regard. But also, when you have an irritant in the gut, it releases serotonin as a product.
Oh, yeah.
And that triggers the vagus nerve to send the signal up to the brain to say vomit.
Also a communication area within your GIT as well.
Yeah. So ondansetron seems to affect both the gut and the brain itself to stop that emetic or vomiting effect. So they give her that. It's a strange case, right? The son's sort of like
it's kind of
not caring.
takes over for the rest of the episode.
Yeah, the son's sort of like just sitting there in the corner on his phone. How's mum? Yeah, she all right? Okay. The mum's like, oh, the husband passed away due to COVID not too long ago, and it's been rough for both of us. And again, that kid seems disconnected, and Dr. McKay sort of sees it, says the potassium's low at 3.1. The mum's like, is that a problem? And she's like, it might lead to some heart issues, but we'll remedy that. Dr. Whitaker, sorry, the med student Whitaker, Dennis Whitaker, meets a new patient, Mr. Milton. So Mr. Milton, his blood pressure is 150/90. Whitaker's like, it's a little bit high. He goes, I've got belly pain, epigastric, so sits above, so like where the stomach is. It was intense after I ate a delicious steak dinner with my wife, took her out for her birthday, and then it sort of went away. And Whitaker's like, well, it could be gallstones. Sometimes when you eat fatty foods, you can get gallstone pain. Can you explain that a little bit? Like the link between, one, what a gallstone is, and two, how fatty foods can trigger a gallstone pain.
All right, so the gallbladder is this organ that just sits under the liver. Its primary job is just to hold bile, which is a byproduct that comes out of the liver. And the bile itself, its job is help to digest. It doesn't break down the fat, it kind of just emulsifies the fat from your diet. So if you have a fatty meal, it works kind of as like a detergent to break up big fat droplets into smaller droplets to then allow the digestive enzymes to work. So anytime you eat a fatty meal, there are chemical hormones that kind of instruct the gallbladder to start contracting.
So it squeezes and pushes bile through some tubes to go into the intestines.
And that's what normally happens for all of us. But if there is irritation, stones, like sandy material, anything that could be a blockage, when it's instructed to contract, it's contracting against irritation, which then causes
or
pain.
around a stone.
Or around a stone.
And that's colic, right? That's sort of a colicky pain, which is
would be-
horrendous.
Yeah, and so usually it's pain maybe half an hour post a fatty meal. So if you're getting that kind of upper right quadrant, kind of where your right rib cage would be, that would be suggestive of potentially a gallbladder pain.
Okay, so Whitaker goes, I think it's gallstone. You had a fatty meal. Maybe you've got gallstone, and like you said, it's contracted around it after the meal. Does the ultrasound and goes, there we go. See a stone, fantastic.
Closed case, he walks off.
See you later. You might just be able to manage it with your diet. As he walks away, the nurse goes, you want to do an EKG? And he's like, why? She's like, well, sometimes epigastric pain can be an indication of heart attack. Yeah. He's like, okay, thanks. Yeah, do that.
So what do you think that represents?
Well, what it's representing is that the wisdom of the nurse and that they've seen this a million times before. It's probably a common presentation, and they probably know that heart attacks can present a multitude of ways, and that while he may have a gallstone...
That could be incidental.
Could be incidental. He might just go, oh, yes, that's what it is. Well, may not. He might have been having an angina or maybe a heart attack. So it goes back to McKay. McKay asks Robbie for help, right? So Robbie's at the nurse's station and she goes, look, I need your help with this vomiting, mum and son. I'm getting a weird vibe, is what she says. She goes, I think it might be elder abuse. Like, she's vomiting. He doesn't have it. Doesn't seem to be an infectious agent. He doesn't care. He might be drugging her or something. So anyway, they go back to that sleeping kid, 4-year-old Tyler, right? Lab results are back. 100% clear.
Everything's normal.
Everything's normal. What's going on? Dr. Langdon is like, have you given him anything? They're like, no. He checks his mouth and he opens his mouth and he goes, are you sure he hasn't eaten anything? Because there's some gelatin in his mouth. Has he had any like pods, like dishwashing pods? The mum's like, no, we don't use that stuff. He's like, gummies? And she's like, nah. And the dad's like, your brother gave me some weed gummies and they're in the pocket of my jacket?
Was it that, or yeah, maybe it was that. I read it as I had some gummies in my pocket and then your brother gave it to him. But maybe you're right.
No. He said when we visited your brother, he gave me weed gummies and I left them in the pocket of my jacket. Yeah. He must have got in there, right? And the mum's like, you idiot, you moron, and says other terrible things. So the mum's obviously not happy. Understandable. Langdon makes a call and confirms, it's cannabis. So that
And I
kid,
liked how he diffused the situation. He just grabbed the dad and said, "Let's talk about this more. Let's go to the room."
yes,
So that's all very difficult in the moment.
absolutely.
Yeah,
So this kid, I mean, I don't know if he's having like the best sleep or the worst sleep of his life, right? I assume being 4 and having that amount of cannabis, it's not a good situation. I assume it's going to be quite a bad. I don't assume that the kid's going to die or anything, but I don't think it's a good situation for the kid. But I don't know. Let's see how this progresses. Anyway, Dr. Robbie's back with the vomiting mum and tells the mum, okay, I need to do a pelvic exam. You probably don't want to be here, to the son. And the son's like, nope. And he legs it and gets out. And the mum's like, why do you need to do a pelvic exam? And he's like, I don't. Let's have a chat. What's going on? This doesn't seem right. And the mum basically says, I gave myself Ipecac to make myself vomit because I need to bring my son in. What's Ipecac?
Yeah, I had to look this up. Ipecac comes in as a syrup, which used to be used to induce vomiting. So I guess if you, in cases where a person might have ingested something that's toxic, you would give this syrup and it would induce vomiting to get rid of that substance.
Yep.
Now, it seems to come from a family like coffee, from the root, and that, or the rhizome, which as a syrup is highly irritant to the stomach wall. And so what that would do to the stomach is cause a huge amount of vagal, which is the nerve that supplies sensory information to the stomach, to be highly activated, going back, as you said, to the vomiting center of the brainstem and just saying, hey, there's something here, get rid of it.
Yeah.
And so therefore inducing significant vomiting.
Yeah. Okay. So, I mean, it sounds like something that would make you vomit. Ipecac. Ipecac has a terrible name. So the dad's like, so the mum goes, my son needs mental health support. Robbie's like, what's going on? He's like, he's made a list of girls at his school that he wants gone or wants harmed. It's not clear, but he says they need to be eliminated or something like that. And Robbie's sort of sitting there going, I don't know what to do. I don't know how to really deal with this. At the nurse's station, Trinity calls Javadi crash again. Javadi's like, please stop doing that. This is ridiculous. And Trinity keeps acting like a pain in the butt. And I don't know if it's her way of connecting or, like you said, trying to create a hierarchy. I just don't think she's good at making friends.
No.
I actually think it's an overconfidence. She's compensating for something. We might find out later on. Robbie sees the social worker at the hospital and says, look, I need you to help me. I need to speak to this kid, right? And basically says that the mum's fine, nothing to worry about really, but brings the kid in.
And the kid, which has been stated at this point, is 18, which means he's now adult.
Yes.
And he can make his own decisions, not the mum driven.
Yes, and so the social worker and Robbie go and speak to the son, separate to the mum, and he's like, why are you talking to me? Like, I've got to be helping my mum. What's this got to do with me? And they're like, if you want to talk about anything, and it can be hard when your dad passes away. He's like, I don't want to talk. I don't want to talk about any of it. And Robbie's like, maybe let's just have a chat. And he's like, I've got to go to school. And he just grabs his bag and walks out, and Robbie follows him. And then the kid starts to run, and Robbie runs out and chases. So he's at the front of the hospital, and the kid runs across the road, and Robbie sort of like drops his head.
Which is interesting there. I mean, it kind of not puzzled me, but made me reflect why he went to that extent to chase him. And I'm guessing it's a difficult situation because it's secondhand knowledge that came from the mum.
Yeah.
Yes, the mum knows the son intimately, but the son is 18, so he has autonomy, and there's also a degree of confidentiality. But there is also the possibility of harm to others.
Yeah.
And so balancing the two.
It's complex.
It is hard.
It's complex.
So you need to ensure you're protecting him and others from harm, but at the same time, there's only so much you can do.
Yeah.
And that's why I was surprised that he chased him down.
No, I mean, I get it. I get it because you need to find out from him firsthand what is the issue, what is he what's going on. So anyway, Rob is out the front. The kid's legged it. He's gone. Nurse Dana comes out and basically says, "Get back in here. We've got a kid with respiratory arrest."
Yeah.
Which is going to be for next episode, right? As Robbie walks back in through the waiting room into the ED, basically has a panic attack. PTSD, freaks out and has a flashback from COVID.
Yeah.
He's in the attire. He's got the, the whole head mask, respiratory gear, PPI
And the whole
on.
ward is...
Whole ward is just filled with sick COVID patients, laying prone. Remember how back when we were looking at all the COVID stuff they spoke about?
All sealed off.
All sealed off. And what ends up happening, so he has this panic attack, flashes it back to COVID, and a nurse walks up to Robbie and says, Dr. Adamson has a pulse ox of 65. So that's measuring his oxygenation. Should be close to 100. It's at 65. Scene ends. Show ends. Episode 1 ends.
Episode ends. Yeah. Lovely.
So, Matt.
Well done.
This is...
You did well there.
You too? Oh, look, I love the show.
I had the easier job.
It's okay. I think setting the scene with everybody...
You did well there,
can be difficult.
Dr. Robbie.
What a man that Dr. Robbie is. So, anyway... hopefully everybody enjoyed this. We're going to be doing more episodes of this, the Pitt rewatch. If you want to ask us questions or have any comments, please send us an email, admin@drmatt.mike. You can contact us on social media at Dr. Mike Todorovic. Please subscribe to our YouTube channel, Dr. Matt and Dr. Mike, and give us a 5-star rating on the podcast as well. Maddie, thank you. Dear listener, thank you, and we'll see you next week.
We'll see you at 8 a.m.
8 a.m. Well, it's not next shift, is it? It's just the next hour of the 15-hour shift.
That's right.
See you soon. Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMikeTodorovic. Speak to you soon.